Electrolytes are the anion and cation. The major cations are sodium, potassium, calcium, magnesium. The anions includes bicarbonate, potassium, sulfate, chlorides. Sources: sodium. It is a major cations of extracellular fluid. Sources: salt, pork, cheese, green olives, corns, bread, potato chips, and processed or canned foods. Average intakes from table salt is 5 to 15 grams per day. Functions: the average serum sodium level is 142 milli equal per liter. Intracellular sodium is 10 milli equal per liter. The responsibility for osmolality of plasma plays a main role in maintaining the normal distribution of water and osmotic pressure in the ECF compartment. Extracellular fluid compartment. It regulates the electrolyte and pH balance of extracellular compartment to control the electrolytic potential of the excitable tissue such as nerves and muscles in the active transport of glucose, galactose and amino acid across the intestinal mucosa. And for sodium, potassium, ATPase. Osmolality: the plasma osmolality osmolarity measures the body's electrolyte electrolyte water balance. The osmolality and osmolarity are measured that are technically different but functionally the same for normal use. The osmolarity is a measure of osmoles of solute per kilogram of solvent, and it is defined as a number of osmoles of solute per liter of solution. Osmolarity can be measured on an analytical instrument called osmometer. Clinical relevance: as the cell membrane is general or freely permeable to water, the osmolarity of the extracellular fluid is approximately equal to that of intracellular fluid. Therefore, the plasma osmolarity is the guide of intracellular osmolarity. This is important as it shows the changes in the extracellular fluid osmolarity have a great effect on ICF molality changes that can cause a problem with the normal cell functioning and volume. If the extracellular fluid was to become too hypotonic, the water would readily fill surrounding cells, increasing their volume and potentializing them cytolysis. The osmolarity of blood increases with hydrations and decreases with over hydrations. In normal people, increased osmolarity in the blood will stimulate secretions anti-diuretic hormone. This will result in increased water reabsorption, more concentrated urine and less concentrated blood plasma. A low serum osmolarity will suppress the release of ADH, resulting in decreased water reabsorption and more concentrated plasma. Osmolarity of the serum or plasma sample can be measured directly, or it may be calculated if the concentration of the major solute are already known. There are many formula used to calculate the serum osmolarity. Clinically, the simple one is serum osmolality divided by millimolar per kilogram is equal to 2 into serum sodium divided by millimolar. And clinical use of the serum osmolality is used in two main circumstances: investigation of hyponatremia and identification of osmolar gap. The urine osmolality is an important test of renal concentration ability for identifying disorder of ADH mechanism and identifying cause of hyper or hyponatremia. Fecal osmolality can be used to assist with diagnosis of causes of diarrhea. Serum osmolality: the serum osmolality is useful preliminary investigation for identifying the cause of hyponatremia. If the patient with significant hyponatria, the serum sodium less than 130 millimolar per liter has a normal plasma concentration. The patient may have a pseudo hyponatremia due to excess lipids or proteins, or samples may have been collected from a drip pump containing dextrose. If the patient has an increased osmolality, it is likely the patient has a reactive hyponatria due to the excess of solute pulling water out of the cell. Examples of this includes glucose in diabetes mellitus or hyperglycemia after transurinal resection of the prostate. Urine osmolality: the urine osmolality is an important test for the concentrating ability of the kidney. The the interpretation of use urea osmolality must always be made in light of appropriate physiological response to the state of hydration of the patient. The test is useful in the following areas for determining the differential diagnosis of hyper or hyponatremia for identification of urine osmolality less than 200 millimolar per kilogram, urine sodium less than 200 millimolar per liter, low sodium serum sodium, patients not dehydrated, and no renal, adrenal, thyroid, cardiac or liver disease or interfering drugs. For differentiating the pre-renal from renal kidney failure, high urine osmolality is consistent with the pre-renal impairment. In renal damage, the urine osmolality is similar to plasma osmolality. For identifying and diagnosing diabetes insipidus, atrial natriuretic peptide, atrial natriuretic peptide ANP is a potent vasodilator and protein secreted by cardiac muscle cells. The atrial natriuretic peptide is a circulating hormone, regulates atrial blood pressure. It controls the body water, sodium, potassium, and fat. This hormone is released by muscle cells of upper chamber of heart when BP elevated. The atrial natriuretic peptide reduces water and sodium and blocks the release of several hormones. The atrial natriuretic peptide produces a pile up and secreted up by mycocytes. The atrial natriuretic peptide level usually increases in the state of hypertension and excess of fluid. Human heart secretes atrial natriuretic peptide and brain natriuretic peptide. Both brain natriuretic peptide and atrial natriuretic peptide level increases hypertension, secondary hypertension and chronic heart failure during heart pacing, chronic renal failure and acute myocardial infarction determined. These receptors are having their own functions and purposes. The atrial natriuretic peptide is having four receptors, that is renal, vascular, cardiac and adipose tissue. The atrial natriuretic peptide attached to the specific group of receptors. These receptors are designed to cause a reduction in blood volume and a reduction in cardiac output and a systematic blood pressure. Renal reduces aldosterone secretion by adrenal cortex. Kidney inhibits renin secretion. In vascular, it relaxes vascular smooth muscles in arterioles. Adipose tissue increases the release of fatty acids from the adipose tissue. Atrial the the atrial natriuretic peptide in combination with the brain natriuretic peptide helps in reducing the volume of blood as well as the excessive pressure on the blood, which allows keeping everything related to the heart and blood to normal level. This ensures best control over the blood flow in our body as well as great control over our entire body and its functions. Deficiency, a nutritional deficiency is highly important. On a low sodium diet, the kidney decreases the excretion of sodium in urine. A low blood sodium triggers the kidney to release angiotensin, which causes the adrenal cortex to secrete aldosterone. The latter induces the renal tubules to reabsorb sodium from the glomerular filter. Hyponatremia refers to the lower than normal level of sodium in the blood. Sodium is essential for many body functions, including the maintenance of body fluid, regulation of blood pressure, and normal functions of nervous system. The hyponatremia has sometimes been referred to as a water intoxication, especially when it is due to the consumption of excess water. For example, during strenuous exercise without adequate replacement of sodium causes. The hypernatremia occurs because of imbalance of water and sodium. Most frequently, it occurs when excess water dilutes the amount of sodium in the body or when not enough total sodium is present in the body. A common classification of hyponatremia is based on the amount of total body water that is present. A decrease in plasma sodium may be due to defect in kidney or adrenal cortex, sweating, burns, vomiting or diarrhea, which can cause loss of sodium containing fluid. In adrenocortical insufficient addition disease, the decrease of serum sodium increases in the sodium excretion or seen normal volume. Euvolemic hyponatremia, the amount of the water in the blood is normal, but an antidiuretic hormone is being inappropriately secreted. secreted from the pituitary gland. This may be seen in patients with pneumonia, small cell lung cancer, bleeding in the brain, or brain tumors. Excess volume, hyponatremia, too much total blood water dilutes the amount of sodium containing in the water. This can be seen in heart failure, kidney failure, and the liver diseases like cirrhosis. This situation is somewhat misnamed because while there is increased total body water, there may be relative degrees of fluid within the bloodstream because the underlying disease fluid leaks into the space between the tissue called third space, causing the swelling of extremities or ascites fluid within the abdominal cavity. Inadequate volume, hyponatremia, the amount of the water in the body is too low or can occur in dehydration. The antidiuretic hormones is stimulated, causing the kidney to make a very concentrated urine and hold in onto water. This may be seen with excessive sweating and exercise in the hot environment. It can also occur in the patient with the excess fluid loss due to the vomiting, diarrhea, pancreatitis, and burns. Other specific situation, hyponatremia. Hyponatremia may be side effect of medications, especially diuretics or water pills used to help control blood pressure. This class of drugs can cause excessive loss of sodium in the urine. Hormonal diseases such as Addison's disease or adrenal insufficiency and hypothyroidism may be associated with a low sodium level. The polydipsia or excess water intake may cause water intoxication, diluting sodium level. This is occasionally associated with the psychiatric illness. In some people who exercise, their concern about the potential for dehydrating causes them to drink more water than they lose by perspiration. This can cause significant hyponatremia and has been known to be fatal in marathon practices who drinks too much fluid without replacing lost sodium in excess of what their thirst mechanism dictates. Symptoms: confusions, nausea and fatigue, seizure. Some individuals do not show any symptoms. Diagnosis of hyponatremia is made by blood test. The measure of concentration of sodium in the bloodstream. The normal sodium level is between 135 to 145 milliequal per liter, and low level is 110 milliequal per liter. Constitutes a true emergency. Other tests may help decide what type of hyponatremia situation exists. The amount of sodium that is being excreted in the urine may be measured, as well as the concentration of the urine. Hyponatremia or hypernatremia is an electrolyte disturbance with the elevated sodium level in the blood. The hypernatremia is generally not caused by an excess of sodium, but rather by a relative deficit of free water in the body. For this reason, the hypernatremia is often synonymous with the less precise term dehydration. Water is lost from the body in a variety of ways, including the perspiration, imperceptible losses from breathing, and it is and in the feces of urine. If the amount of the water ingested consistently falls below the amount of the water lost, the serum sodium level will begins to rise, leading to the hypernatremia. Rarely, hypernatremia can result with a massive salt ingestion. Even a small rise of the serum sodium concentration above the normal range results in a strong sensation of thirst and increase of free water intake and correction of abnormal. Therefore, the hypernatremia most often occurs in people such as infants, those with impaired mental status, or elderly who may have an intact thirst mechanism but are unable to ask for about water. Causes: decreased activity of ADP, hyperactivity of adrenal cortex. Common causes of hypernatremia includes hypovolemic, inadequate intake of water, typically in elders or otherwise disabled patients who are unable to take in water as their thirst dictates. This is the most common cause of hypernatremia. Excessive loss of water from the urinary tract, which may be caused by glycosuria or other osmic diuretics. Water loss is associated with the extreme sweating and severe water diarrhea. Volumic excess excretion of water from the kidney caused by the diabetic insipidus, which involves either inadequate productions of hormones, vasopressin from the pituitary gland, or impaired responsiveness of kidney to the vasopressin. Hypervolemic intake of hypertonic fluid, a fluid with a higher concentration of solute than the remainder of the body. This is relatively uncommon, though it can occur after a vigorous resuscitation, where a patient receives a large volume of a concentration of sodium bicarbonate solution. The ingestion seawater also causes a hypernatremia because seawater is hypertonic. There are several records caused to force ingestion of a concentrated salts solution in exorcism rituals leading to death. Mineralocorticoid excess due to the disease states such as Cohn's syndrome or Cushing syndrome. Sign of symptoms: lethargy, restlessness, spasticity, edema, seizures. Treatment: the treatment in the administration of free water to correct the relative water defect. Water can be replaced orally or intravenously. Water alone cannot be administered as intravenously. Rather can be given with addition to dextrose or saline infusion solution. The body that adapts to a higher salt concentration. Rapid lowering of sodium concentration with free water may causes water to flow into the brain cells and causes them to swell. This can lead to the cerebral edema, potentially resulting in seizure, permanent brain damage, or death. Therefore, the significant hypernatremia should be treated carefully by physicians or other medical professionals with experience in treatment of electrolyte imbalance. Determination of sodium: the serum, heparinase, plasma, sweat, urine, feces, or gastrointestinal fluid are used for the assay. The hemolyzed samples are not suitable for electrolyte analysis because the RBC releases potassium, which will cause a false result in K plus value. The hemolysis causes a decrease in sodium value also. Urine collection for electrolyte estimation should be made without any preservatives. The serum, plasma, or urine must be stored at 2 to 8 degrees centigrade or frozen if analysis is delayed. Sodium may be determined by atomic absorption spectrometer, flame emission spectrometer, electrochemical with sodium ion selective electrode, or spectrophotometrically. The FES are the flame emission spectrophotometer, and ion selective and ion selective electrodes assay are currently used because of their accuracy. Reference intervals here: serum is 138 to 145 milli equal per liter. Potassium is the most important cation of intracellular fluid. Average concentration of intracellular fluid is 150 milli per liter. Extracellular potassium concentration is normally kept within the tight range of 3.5 to 5 milli per liter. The extracellular potassium is important for its controlling influence upon neuromuscular irritability, cardiac muscle. A proper balance between the potassium and calcium is essential for the contraction of heart muscles and the operation of the sodium potassium ATPase against the concentrated gradient. In cells, there is a significant concentration gradient of sodium potassium across cell membrane. The high intracellular potassium is maintained by an energy requiring extrusion of 3 sodium out of cell with replacement by 2 potassium. The intracellular potassium is essential for a number of enzymes reactions such as pyruvate kinase, glycogen synthesis, and protein synthesis for maintaining osmotic and acid base balance. Nearly all the total body potassium, 19% in the inside cell. For example, there is a significant tissue damage. The content of cells, including a potassium, leak out into the extracellular component, causing the potential dangerous increase in the serum potassium. Sources: whole and skim milk, bananas, tomatoes, oranges, melon, potassium, sweet potatoes, spinach, turnip, greens, other green leafy vegetables, peas, beans, and salt. Substitute. The function: it is a principal cation, ICE. The potassium is required for the functioning of nerves, skeletal muscles, cardiac muscles. Either decrease potassium or increase potassium level finally causes cardiac arrest. The potassium is required as a cofactor in several enzymatic reactions in the body. Potassium is involved in acid-base balance. Hypokalemia. Hypokalemia is a metabolic disorder that occurs when the level of potassium in the blood drops too low. It is the condition in which serum potassium is reduced. This condition decreases the heartbeat and interferes with the vital muscles, such as those involved in respiration. Possible causes of hypokalemia includes antibiotic, penicillin, ampicillin, cabrenolysin, gentamicin, amphotericillin, and B. Foscarnet, gastrointestinal loss. A most common cause is excessive loss of potassium, often associated with a heavy fluid loss that flushes potassium out of the body. Typically, this is a consequence of diarrhea, excess perspiration, or loss associated with the surgical procedure. Vomiting can also cause hypokalemia, although not much potassium is lost from the vomitus. Rather, there is a high urinary loss of potassium in the setting of a post-emetic bicarbonaturia that forces urinary potassium excretion. Other gastrointestinal causes includes pancreatic fissures and presence of adenoma disease. Disease that affects the kidney ability to retain potassium. Diuretic medications which can cause excessive urination. Eating disorder such as bulimia. Magnesium deficiency. Magnesium is required for adequate processing of potassium. This may become evident when hypokalemia persists despite potassium supplement. Other electrolyte abnormalities may also be present. Sweating, vomiting. Since aldosterone increases the excretion of potassium or administration of cortisone leads to the hypokalemia. Certain diuretics increases the excretion of potassium. It is therefore important to supplement enough potassium when these diuretics are used. Reduced intake of potassium may cause hypokalemia, but it is rare. Renal retention of potassium in response to reduced intake ensures that hypokalemia occurs only when intake is severely restricted. Several factors regulate the distribution of potassium between the intracellular and extracellular space as follows. Glycoregulator hormones. Insulin enhances potassium entry into the cell, and glycogen impairs potassium entry into the cells. Adrenergic stimuli. Beta adrenergic stimuli enhances potassium entry into the cell. Alpha adrenergic stimuli impairs potassium entry into the cell. Therefore, there is a risk of hypokalemia when insulin gives in treatment of a diabetic ketoacidosis. pH. Alkalosis enhances potassium entry into the cell. Acidosis impairs potassium entry into the cell. Alkalosis can cause a transient hypokalemia by two mechanisms. First, the alkalosis causes a shift of potassium from the plasma and interstitial fluid into the cell, perhaps mediated by the simulation of a sodium and hydrogen exchange and subsequent activations of sodium potassium ATPase activity. Second, an acute rise of plasma HCO3 concentration will exceed the capacity of a renal proximal tubule to reabsorb this anion, and potassium will be excreted as a observed cation partner to the bicarbonate. The metabolic alkalosis is often present in the state of volume depletion, so potassium is also lost via adenosterone mediated mechanism. Hypokalemia. The pseudo hypokalemia is a decrease in the amount of potassium that occurs due to the excessive uptake of potassium by metabolically active cells in the blood samples after it has been drawn. It is a laboratory artifact that may occur when blood sample remains in warm conditions for several hours before processing. Symptoms: a small drop in potassium usually. A small drop of potassium usually does not cause symptoms. However, big drop in level can be life-threatening. The symptoms of hyperkalemia includes abnormal heart rhythm, especially in people with heart disease, constipation, fatigue, muscle damage, muscle weakness, or paralysis. Signs and tests: the serum potassium determination, atrial blood gases, basic or comprehensive metabolic panel, electrocardiogram, a blood test to check glucose, magnesium, calcium, sodium, phosphorus, thyroxine, and aldosterone level. Treatment: mild hypokalemia can be treated by taking potassium supplement by mouth. A person with more severe cases may lead to get potassium through the veins. If diuretic use, doctor may try to keep potassium in the body. One type of hypokalemia that causes paralysis occurs when there is too much thyroid hormones in the blood. The treatment lowers the thyroid hormone level and raises the potassium level in the blood. Hyperkalemia The elevated plasma potassium concentration it occurs in Addison's disease and in intravenous infusions of potassium at the rate excess of 25 millimolar per hour. The treatment using the concentration potassium solution causes renal insufficiency, medication that interferes with the urinary excretions. The ACE inhibitor and angiotensin receptor blockers, potassium sparing diuretics, NSAIDs such as ibuprofen, naproxen, and celecoxib, the calcineurin inhibitor, immunosuppression presents cyclosporin, and tacrolimus, the antibiotic trimethoprim, the antiparasitic drug pentamide. The mineral corticosteroid deficiency or resistance such as Addison's disease, aldosterone deficiency, some forms of congenital adrenal hyperplasia, the type 4 renal tubular acidosis, resistance of renal tubules to aldosterone, Gordon syndrome, or rare genetic disorder caused by the defective model of salt transporters, including the thiazide sensitive NaCl contrasporter, excessive release from the cell, the rhabdomyolysis, burns, or any causes of rapid tissue necrosis, including tumor lysis syndrome, the massive blood transfusion or massive hemolysis, shift to transport out of the cell caused by the acidosis, lower insulin level, beta blocker therapy, digoxin overdose or a paralyzing agent, succulent choline, excessive intake with salt, substitute potassium containing dietary supplement or potassium chloride infusion. Note that for a person with normal kidney function and nothing interfering with the normal elimination, the hyperkalemia by potassium intake would be seen only with a large infusion of potassium chloride or oral doses of several hundreds of milliequivalent of KCl. Pseudo hyperkalemia. The pseudo hyperkalemia is a rise of amount of potassium that occurs due to the excessive leakage of potassium from the cells during or after blood is drawn. It is a laboratory artifact rather than biological abnormalities and can be misleading to caregivers. Pseudo hyperkalemia is typically caused by the hemolysis during the vein puncture, excessive tourniquet time, or fist clenching during the phlebotomy. Leads to the efflux of potassium from the muscle cells or into the bloodstream, or by delay in processing of blood samples. It can also occur in specimen from the patient with an abnormal higher number of platelets, less than 5 lakhs 5 lakhs millimolar cube, or leukocyte with less than 70,000 millimole, or erythrocyte with hematocrit less than 55%. The tissue trauma causing the cells to release potassium into the ECF includes burns, traumatic injury, and intestinal bleeding. Signs and symptoms: fatigue, weakness, tingling, numbness, paralysis, palpitation, and difficulty in breathing. Test to gather enough information for diagnosis. The measure of potassium needs to be repeated as elevation can due to the hemolysis in the first sample. The normal serum level of potassium is 3.5 to 5 milliequal per liter. Generally, blood test for renal function and glucose performed. The calculation of calculating the transtubular potassium gradient can sometimes help in distinguishing the cause of hyperkalemia. In many cases, the renal ultrasound will be performed since the hyperkalemia is highly suggestive of renal disease. Also, electro ECG may be performed to determine if there is a significant risk of cardiac arrhythmias. Treatment: several agents are used to consistently lower potassium level. Choice depends on the degree and cause of hyperkalemia and other aspects of patient conditions. Insulin will lead to the shift of potassium ions into the cell. The secondary to increase activity of sodium potassium ATPase. Its effect lasts a few hours, so it sometimes leads to repeated, while other measures are taken to suppress the potassium level more permanently. Severe cases requires hemodialysis or hemofiltrations, which are most rapid method of removing potassium from the blood. Preventing recurrence of hyperkalemia typically involves involves a reduction of dietary potassium, removal of any offending medications, and/or the addition of oral bicarbonate or diuretics, such as furosemide or furosemide or hydrochlorothiazide. Normal range in serum 3.5 to 5 milli equal per liter, in plasma 3.5 to 4.5 milli equal per liter. Serum potassium level above 7 milli equal per liter and below 2.5 milli equal per liter is serious, life threatening, and requires immediate attention. Specimen serum heparinase, plasma, sweat, urine, feces, or gastrointestinal fluid are used for assay. The hemolysis samples are not suitable for electrolyte analysis because the release of potassium from the RBC, which will cause a false increase in potassium value. The urine collection for electrolyte estimation should be made without any preservatives. Serum, plasma, or urine must be stored at 2 to 4 degrees centigrade or frozen if the analysis is delayed. Assay of potassium: flame emission spectrophotometry, ion exchange electron method. Specific electrode for sodium and potassium are used in this method. The above two methods are more popular and commonly used. Atomic absorption spectrophotometric method, determination of sodium, potassium in serum using the emission frame photometer sample. The sample is diluted and fed into the non-luminous flame in the form of fine spray. Sodium and potassium elements gives out a characteristic color in the flame. The sodium gives us yellow and potassium violet color on the ignition in the flame. Yellow or violet flame thus emitted in the proportional to the sodium or potassium content. The separate color filters are used for the sodium and potassium.